Well, I must admit that speaking to this audience, I felt compelled to at least start with this slide, which puts my presentation in perspective. This shows the role of thrombus and ST segment elevation, myocardial infarction. If you look here at the non-ST segment elevation or unstable angina with its ECG, this results from stabilization of a platelet aggregate at the site of a plaque rupture, and you can see that there are still channels for blood to flow to the myocardium. Whereas STEMI, with its ST segment elevation, is really a thrombus in the coronary artery that's occlusive. So it's easy to see, particularly for the patients in the audience, why STEMI really represents a medical emergency. And in fact, the relationship between reperfusion and restoring blood flow and mortality, the chance of dying from a heart attack, is actually measured in minutes. The good news is that we have very effective treatments for STEMI, reperfusion therapies. First, fibrinolytic therapy, which is widely available, probably in every acute care hospital. It's quickly administered via intravenous route, but it's less effective than angioplasty or primary PCI, and it has a higher bleeding risk. Primary PCI, primary specific to PCI for acute myocardial infarction for STEMI, requires a cath lab. So there's limited availability, there's the inherent treatment delay, but it is more effective and the bleeding risk is lower. But it's important that it's only more effective if it could be delivered in a timely fashion, and time is critically important. Shown here is symptom onset to balloon time and mortality at 1 year following primary PCI. This is a pooled analysis from 6 randomized trials by the Zvoli group, showing that the relative risk is 1.08 for each 30-minute delay, such that mortality is increased by 7.5% for each 30-minute delay from symptom onset to restoring blood flow and balloon inflation in the cardiac cath lab. While symptom onset, the total ischemic time, is really what's critically important. The metric has always been door time. It's more accurate, it's easier to measure. Shown here is door to balloon and mortality. This is now adjusted mortality in 43,000 patients from the ACC NCDR registry. Again, a curvilinear relationship. The longer the door to balloon time, the higher the mortality. And the guidelines, as you know, recommend 90 minutes, which breaks right around here, but it's important that even less than 90 minutes is better. Well, it's not surprising that since primary PCI is the preferred reperfusion strategy, there's an inherent delay. We continue to look for strategies to decrease door to balloon time. These data are published by Bradley and colleagues. Survey data found 6 effective strategies: having the ED physician activate the cath lab, providing real-time feedback to the team, looking at every patient, what went wrong, what could do better, using a single call page system, having a cardiologist on site, having EMS diagnose STEMI en route to the hospital so you can alert the hospital, and requiring that the cath lab team mobilize in 20 minutes. Based on these and other data, the American College of Cardiology launched the Door to Balloon Alliance in 2006, an effective campaign in 1,000 hospitals, looking at core strategies and helping hospitals achieve these with having the ED physician activate the cath lab. One call activates the cath lab team mobilizes quickly. There's prompt data feedback, senior management commitment. The hospital administration has to be behind this, and a team-based approach. In 2007, the American Heart Association looked at a systems-based approach to improving care for STEMI patients, improving the quality of care and outcomes for patients with STEMI, and improving the healthcare system readiness and response to STEMI. Mission Lifeline is a comprehensive initiative that really addresses the continuum of care from the STEMI patient, for the patient's entry into the system, their foray with the ambulance and emergency medical systems, their transport between the referral hospital that doesn't provide PCI to the STEMI-Receiving hospital, and importantly includes policymakers, health agencies, and payers. Mission Lifeline proposed ideal strategies based on a stakeholder conference, ideal strategies from the perspective of each stakeholder. So shown here is the ideal system for the STEMI-Receiving hospital. Similar strategies: pre-hospital electrocardiogram, ED notification, and cath lab activation to occur according to protocols, single call systems from the STEMI referral hospitals, primary PCI provided 24/7, a multidisciplinary team, a continuing education program, and a mechanism for monitoring performance and process. Mission Lifeline also looked at the ideal system from the perspective of EMS and said ambulances should be equipped with 12-lead ECG machines, the providers need to be trained, there needs to be standardized point of entry protocols defining where a patient goes. Do they go to a non-PCI hospital directly or to a PCI hospital? When there's a STEMI, the cath lab is activated promptly. In Boston, we call that a STEMI alert. Patients are transported to a STEMI referral center, remain on the stretcher until the decision is made, and then they're taken to the PCI center. And if you transport yourself to the hospital, and you need to be transported to a hospital that provides PCI, you activate EMS, and it's not a next ambulance, but it's a 911 mechanism. And these strategies and systems, the Door-to-Balloon Alliance and Mission Lifeline and others, have been enormously effective in decreasing door-to-balloon time for patients that present directly to hospitals that provide PCI. So these data are from CMS, 50,000 patients looking at door-to-balloon time between 2005 and 2010, published by Harlan Krumholtz and colleagues. And you can see that the trend, 44% in 2005, 91% patients now have a door-to-balloon time within the guideline recommended 90 minutes if you present directly to a hospital providing PCI. But the issue is that there are 5,000 acute care hospitals in the country, and about 1,700 of them have cath labs. So the majority of patients don't present to a cath lab hospital. And we have to transport those hospitals. And we know that there's an inherent delay and less progress has been made in patients who have to be transported. Shown here is the door-to-balloon benchmarks for transfer patients in 2010 and 2011. And you can see that only 27 or 30% of patients meet this metric within 90 minutes. And even for 120 minutes, about 50% of patients are treated within the guideline recommended. Now it's actually changed to 120 minutes from first medical contact to balloon inflation in the second hospital. So more work has to be done. And it seems like much of the inherent delay is in the hospital, the referral hospital. This is now called DITO, or door in and door out time, and these data are also from CMS and 13,000 patients. The metric or the performance measure from ACC-AHA is 30 minutes between the time you get into the referral hospital and the time you get out. You can see that less than 30 minutes only occurs in 9.7% of patients and greater than 90 minutes in 30% of patients. So clearly, more work needs to be done and the focus needs to be on door in and door out. These data are the median door in and door out times for the hospital, ED, and EMS processes. These data are from the RACE initiative. This is championed by Chris Granger, who will be speaking here a little bit later. And RACE has organized the state of North Carolina into STEMI systems. And they've shown that if you follow certain hospital processes so that you have a STEMI team and a leader and that you have specific reperfusion protocols, if you have ED processes where you have your ECG done within 10 minutes, you have a one-call activation, EMS processes that you get an ECG en route to the hospital, the paramedics are trained to read it, you have local ambulances transport patients, and you keep the patient on the stretcher while the decision is made to go to a PCI hospital. If you put all these together and actually combine them, you can really significantly decrease the door in and door out time. So more to come. But the real issue is the patient. And here's where we have made the least progress in having the patient decrease the symptom onset to delay time. Shown here are data from a consortium of hospitals in Michigan looking at the quartiles of patients. So the quartiles really just look at low risk and high risk patients. Between 2003 and 2008, no change in the time from symptom onset till the patient comes to the hospital. No change in all of those years. Similar data, this is from the Global Registry of Acute Coronary Events. This is an international registry now, again, 2003 to 2007. And if you just focus on the primary PCI, although it's the same for fibrinolytic therapy, and you look at the dark bars, that's symptom to door time, no change in all of these years between symptom onset and door time. So clearly, we're not getting to the patients. Once they get to the hospital, we've made the progress, but getting them to the hospital has been our challenge. This looks at the delays from symptom onset to primary PCI. These are from Denmark, these data. Turkelson and colleagues sort of defined the parameters. So symptom onset to EMS call, that's the patient delay. EMS call to arrival at the PCI center is the transportation delay. And then the door-to-balloon time is the door-to-balloon time delay. The system delay starts from that first medical contact to balloon inflation, and the treatment delay starts from the patient's symptom onset. And the bottom is if you have to be transferred, so you add the local hospital delay and the inter-hospital transport delay. And what they found is that there's a definite relationship between a system delay and mortality. The longer the system delay, the higher the mortality, and it was more potent for the system delay than it was for the patient delay or even the door-to-balloon delay. So clearly systems of care are important and where we need to go. Shown here are the systems of care registered with Mission Lifeline 1 year after Mission Lifeline were launched. 87 systems, and a system is defined as a referral hospital, a receiving hospital, and one EMS. It could be as small as that. 24% of the population was covered. This is where we are in 2012. We have 615 systems registered with Mission Lifeline, 61% of the population covered. And this has been the progress, looking at the median door-to-balloon times between 2007 and 2011. 169 minutes to 190 minutes if you have to be transferred. Clearly, we haven't met the guideline standard. And if you're the direct presenter, 79 minutes to 61 minutes. So progress has been made, but really more to come, and the focus now needs to be on the patient and probably that door in and door out time at the referral hospital. Thanks very much.
Well, you've really done amazing work. I'm sure you've been in multiple meetings to really get buy-in and consensus. What do you do when you're sitting around the table with the CEO of a community hospital that doesn't offer PCI and propose that not even to stop there for thrombolytic therapy or evaluation first, but just to literally have the ambulance drive by it? As hospitals struggle to maintain census, what arguments do you make, and how do you move the discussion forward?
So, of course, very challenging. That is very challenging. It's less challenging if you're at the referral hospital because, you know, speaking with the payers, CMS, there's talk about incenting the entire system so that everybody gets incented and payment for treating patients by the guidelines if you're at the referral hospital and rapidly transporting them to another hospital. It's much more difficult if you're really the have-not, if your hospital is going to be bypassed, because we know that those community hospitals are important, and that's really been the challenge. It's really even more at the table with hospitals that are referring the patients, and that seems to really be working. It seems to putting all the right incentives in place and the right reasons in place and giving the data back, that seems to be less of an issue. The hospitals that are bypassed, we have to watch closely. When we put this together in Boston, right here in Boston, we had that. We had a data monitoring safety committee, and we looked at hospitals and made certain that it was really only the STEMIs that were bypassing the hospital. But you know there's a halo effect, and if patients have chest pain, they could have a STEMI, and they're not taken to that hospital. So clearly something that we have to, we don't really know what the impact is, but that has to be defined.
One other question for you, and we've talked about this informally. The other two sections of our program are on stroke and pulmonary embolism. How do you expand your model?
Great question. When we really first had the vision for Mission Lifeline, STEMI was the low-hanging fruit. It's actually only 20 to 30% of MIs, and yet we started with STEMI. It was the medical emergency. But the concept was that if you really got the hospitals and the systems working together, so EMS and the different hospitals working together, we had this balloon slide where you can extend it, so we will extend it to ACS and the time-sensitive disorders, particularly under the AHA umbrella, so stroke. Mission Lifeline has now, just in the past couple of months, incorporated out-of-hospital cardiac arrest. So that vision is on the table, and I always, whenever I'm asked this question, always refer to you. I said, Sam Goldhaber wants to know when we will do it for pulmonary emboli. So stay tuned. But that's really the concept behind it, that if you put these systems in place, it will be for all time-sensitive disorders.
Great. Alice, thank you very much.